Officer at WHO, and welcome to the WHO Africa briefing on the Ebola disease outbreak declared in Uganda earlier this week. We have received a lot of queries from journalists but couldn't answer all your questions individually, so we are focusing this press briefing on the current situation in Uganda. We gathered specialists to update you on the latest developments and bring you also all available technical information on vaccines and treatments. First, some housekeeping. You can choose the language you would like to hear for the press conference by turning to the globe on the bottom right and selecting your language. La conférence de presse va se dérouler en anglais, mais vous pouvez choisir la langue dans laquelle vous souhaitez bénéficier de la traduction en cliquant sur le globe en bas à droite et en sélectionnant votre langue. So let's introduce our panelists. Joining us from Brazzaville in the Republic of Congo is Dr. Patrick Otim, who is leading WHO's response to the Ebola outbreak. Joining from Kampala, we have Dr. Kyobe Henry Bosa, Ebola Incident Commander, Ministry of Health of Uganda. Tuning in from Geneva, we have Dr. Anna Maria Henao Restrepo, an expert on Ebola vaccines, WHO Health Emergencies Program, and from the USA, Dr. William A. Fisher, a specialist of infectious diseases and expert on the treatment of Ebola, University of North Carolina. A warm welcome to you all. So let's start. One recurring question we have received is the difference between the Sudan Ebola virus, which is causing the current outbreak in Uganda, and the Zaire Ebola virus, which is what has been behind the recent outbreaks. So I go over to Dr. Otim to explain it to us. Dr. Otim, you have the floor.
Thank you very much, Rosemary, and good morning to journalists and all viewers joining us on this press briefing. So I would like to start explaining the difference between the Sudan Ebola virus and the Zaire Ebola virus. Let me just start with a brief history. So in 1976, we had two simultaneous outbreaks, one in the Yambuku area in the former Zaire, now called Democratic Republic of Congo, along a small river called the River Ebola, and then in the southern part of the then Sudan, but the present day South Sudan, in a county called Nzara. Now, the viruses isolated from these two different locations were given the name Ebola Zaire for the one from the DRC and Ebola Sudan for the one from the southern part of Sudan then. So when we look at these two viruses and try to compare, we will largely look at three areas. One, in terms of the epidemiology, there may be different things that we can use to explain. But when we compare the Ebola Sudan, which is what we have now in Uganda, and the Zaire Ebola, which has recently been also confirmed in DRC, it is noted that from previous outbreaks, the Ebola Sudan is less transmissible. That is, the ease for it to pass from one person to the next. So it is less transmissible than the Ebola Zaire. The second other thing is that in terms of the mortality, the mortality with the Ebola Sudan in the previous outbreaks has been seen to be relatively lower. So we have between 40 to 100% case fatality rate compared to 70 to 100% in the Ebola Zaire. Now, the other last thing I want to talk about is that for clinicians, usually we want to see the clinical differences. Now, it's always very difficult for these two viruses because when the disease starts, it is non-specific symptoms, but there are certain things that we can be able to see. For instance, for the Ebola Sudan, there is a commonly found chest pain, which was one of the things that was seen in this patient in the first case that was confirmed in Uganda. The chest pain is not very prominent in the Ebola Zaire. The second one is also then in terms of the bleeding manifestations. So you will find that in the Ebola Sudan, which we are dealing with, the redness of the eye, which is conjunctivitis, and the vomiting of the blood, which is hematemesis, is much, much more common. However, I would like to add that for both these viruses, if we do not initiate treatment early, sometimes even the Ebola Sudan, which we are saying is much more less in terms of case fatality rate, can cause more deaths. Then second caveat is that for the Ebola Zaire, which we have had some advancement in terms of availability of vaccine and therapeutics that my other panelists will talk about, it may contribute in the recent outbreaks to a reduction in the mortality compared to Ebola Sudan. So it's very, very critical that at this point we treat this outbreak as serious, because we may not have the advantage that we have gained in terms of the advancement in medical countermeasures.
Thank you very much, Dr. Otim, for this comprehensive answer. Now, let's turn to the other panelists to give us more insights on this outbreak. And first, let's go straight to the Uganda Ministry of Health Incident Commander for the Ebola response to understand the current situation in the country. So Dr. Kyobe Hanubosa, can you update us on what we know about the outbreak so far?
Thank you so much, Rosemary. As of today, we have 7 confirmed cases, of whom we have 1 confirmed death, but also have 7 probable cases that died before the confirmation of the outbreak. And currently, we have listed up to 11 contacts and been able to trace up to 43. To give you a background, the epidemic appears to have started around the beginning of September, when people started dying in a small village in a sub-county called Madudu in Uwende district, deep in central Uganda. And then it was not until the 19th when a 25-year-old male presented to a regional referral hospital with the symptoms consistent with what Otim has just spoken about. And this individual had been treated in several places and were able to identify the Ebola Sudan virus from Uganda Virus Research Institute. So since then, additional 6 cases have been confirmed, and of these are coming mainly from 5 sub-counties within Mubende district, which is in central Uganda, but also seeing that 1 case may have come from another district, neighboring district, which is Chegegwa. Of note, this Mubende district lies on a major highway that leads into Kampala from DRC and has busy trading places and a gold mine on one side, very close to where the current epicenter is. So in terms of what has been done so far, we have listed over 43 contacts. We are continuing in the contact tracing, and we are repurposing and extending the treatment center, which had actually previously been used for COVID, and enhancing public awareness. Of course, as you know, that Uganda has had a number of Ebola outbreaks. This is the 3rd Ebola Sudan outbreak. The first was in 2000, where we had over 200 deaths. And the second one happened in 2012 in central Uganda, a little bit far from where we are now, and then the current one. So since then, we've had significant expertise back then to be able to respond to this. So briefly, that's the picture that we have in Uganda. Over to you, Rosemary.
Thank you very much, Doctor. So we also had a lot of queries from journalists about vaccines. So over to you, Dr. Anna Maria. Can you tell us if there are vaccines which work against the Sudan Ebola virus species, and what research is being done?
Thank you. Good morning, good afternoon, good evening, everybody. I am here with my colleague, Professor Cesar Munoz Fontela, who is from the WHO Collaborative Center for Arbovirus and Hemorrhagic Diseases. So we will try to answer your questions. The first thing that I want to say is that in WHO, we have listed for many years Sudan virus as an important virus. It's part of the priority list of the research and development blueprint. When we do that, when we list the virus as a priority virus, we develop what we call a research roadmap. It's a roadmap that outlines what research is required and what are the knowledge gaps for this virus. So we have two global consultations earlier this year to look into these research gaps, led by Professor Cesar Muñoz Fontela and other colleagues, and they are available in our internet. From that, we uncovered that there are several candidate vaccines for Sudan virus, Ebola virus, in development. And there are at least 6, maybe more vaccines. We are contacting all the developers, and we have already the first discussion with the developers and the experts yesterday evening. Of these vaccines, 3 vaccines have already what we call clinical data. It means it has been given to some humans to assess the safety and the immunogenicity, 3 of these vaccines. The second step to choose which vaccines to move forward to evaluate in the context of this outbreak to see if they are efficacious is to identify whether or not these vaccines have all the documentation and the data that is required by regulators to approve a clinical trial protocol in Uganda or in any part of the world. And also whether or not they have the doses of the clinical grade material, vaccine doses that fulfill the international standards. So yesterday we talked to them and they all committed to move as fast as possible to put the available doses into vials so that WHO, in collaboration and in coordination with the Ugandan government and the National Regulatory Authority in Uganda, can decide if one or more of them could be deployed and evaluated during the outbreak. That's the first step. The second long-term part of our roadmap is to continue to fill all the research gaps, including for treatments for Sudan Ebola virus, to ensure that in the future we have good interventions like we do for the SARS virus. And to finalize, I just want to say that there is a lot of discussion on whether or not the vaccines we use for the SARS virus will work for Sudan. So there is one of the candidates for which the data suggests it will not. There is no what we call cross-protection, protection across the virus families. But for the other one, there is only preliminary phase 1 data. So there is some suggestion that at least one, and this one is among the 3 that could be considered for deployment if all the conditions I just mentioned are fulfilled. So, and then finally, I want to say that Sudan outbreaks tends to be small. So they tend to present a challenge for researchers because fortunately the number of cases is small, so the number of data that you can accumulate in one outbreak is limited. This is why WHO has worked with international clinical trial experts to develop a protocol that is ready that could allow us to accumulate evidence between one outbreak and the following one until we are certain of the clinical efficacy of a vaccine. And I would like, if I may, to ask Professor Cesar Muñoz Fontela to add anything if I miss anything. Thank you.
Thank you, Ana Maria, and good morning, good afternoon, good evening, everyone. I don't have much to say, just maybe reinforce. I mean, I would probably have a message of caution and a message of hope, because I think we need to be cautious because, as Ana Maria mentioned, we had a relatively low number of cases historically of Sudan virus. So I think it will be difficult to predict, you know, pathogenicity, transmissibility, other manifestations, because history showed us that we learn a lot from the Ebola Zaire outbreaks, especially from the West African epidemic, due to the number of individuals that were infected. So that's a message of caution. A message of hope is that, as Ana Maria mentioned, there's different platforms already with vaccine candidates. We know a lot about these platforms. Some of them have been used already for Ebola Zaire. And in general, I think we are much better prepared now than we were before the West African epidemics, with a lot of expertise in the field teams, and knowing a lot, much more about research, about pathogenicity, immunogenicity, and so on. So I think we will be better prepared this time. Thank you.
One final point on preparation. We are very lucky because the Ugandan researchers have lots of experience in dealing with filoviruses, Ebola, etc. And they have also expertise in conducting clinical trials, including what we call revaccination. So this preparation is not only a global preparation, but we count on a cadre of expertise at the country level that is critical and very important. And we salute the researchers in Uganda for their high quality work.
Thank you very much to you both. So I remind that we had Dr. Anna Maria Restrepo from WHO Health Emergencies Program and Professor Cesar Munoz Fontela from Bernard North Institute for Tropical Medicine and WHO expert in Ebola vaccines research. So now let's turn to Dr. Fisher to discuss treatment options for the Sudan Ebola virus species. Over to you, Dr. Fisher, to give us some insights.
Great. Thanks, Rosemary, and good morning, good afternoon, and good evening to everyone. I think we've learned a lot about infections with Ebola viruses over the past decade, including how to improve survival with really good clinical care. And in the past outbreaks, we've seen that survival is highest among people who are younger, people who tend to have lower levels of virus, people who have good organ function, meaning that the infection has not progressed to cause organ injury, and people who present earlier after their symptom onset. And so I'm going to really focus on those last two factors, which I think are critical, because specifically good organ function and presenting early to a treatment center, because good supportive care is available right now. And when started early, it can save lives. And so specifically what I'm referring to is that good supportive care can improve survival in severe viral infections by protecting against organ injury if we're able to start that treatment early. In situations where organ injury has already occurred, supportive care can help us manage the complications of that organ injury. And good supportive care can also prevent further deterioration of that organ injury. And so I'll give you a couple of examples. So I've seen a number of patients with Ebola virus disease that have low blood pressure from both the infection, but also from fluid loss, from diarrhea or vomiting, or not being able to eat or drink very much because they feel so sick. In fact, up to about 30% of people can present like that. And low blood pressure can be really dangerous because blood pressure is what delivers oxygen and nutrients in our blood to all of our organs. And so decreased pressure can lead to organ injury. But if we catch it early, we can reverse it and we can prevent it. We can use fluids and special medications to support the blood pressure and maintain good blood flow to the organs. We've also seen patients with dangerously low blood sugar levels that can cause serious complications such as seizures. And this is really important because it's easily treatable, but it requires close monitoring, and it's available, and that monitoring and care is available at treatment units. One of the other really common complications of Ebola and Sudan virus disease are kidney disease, or kidney injury. And this is quite common among patients who present with both of these infections. And kidneys are important for clearing waste from our blood, for managing electrolytes such as potassium and sodium and the amount of water in our body. And so when they're injured, we can see changes in all of these, which can be dangerous. But just like low blood sugar levels and low blood pressure, this is treatable. And with good supportive care, we can maintain good, safe levels of electrolytes, manage the fluids in our body, and work to prevent further injury to the kidneys. So this supportive care really represents what I would argue is the foundation of all care for severe viral infections. And the Ugandan Ministry of Health has really taken a leadership role in the region in preparing for Ebola virus outbreaks, and recently conducted a 5-country training on supportive care just this past month. And so I think this really this is something that we can provide right now, good supportive care, but it requires patients to come early. It gives us our best chance to help them. Over.
Thank you very much, Dr. Fisher. And so I'd like to turn back to Dr. Otim to hear about what WHO is advocating and doing in terms of response, given everything we know so far about the Sudan Ebola virus. Dr. Patrick, over to you.
Thank you very much, Rosemary. And I think I would like to start by stating that WHO's work with the member states, particularly Uganda, has focused a lot on developing capacity for outbreak response before the outbreak actually happens. And like Dr. Fisher has just mentioned, we worked with Uganda just last month to train clinical care providers in Uganda, but also neighboring 4 countries to be able to be ready to respond to public health event, particularly outbreak like for the Sudan Ebola virus that we're dealing right now. And it was a very comprehensive training with experts from around the globe facilitating. Now, the second thing that we always do is also strategic prepositioning of supplies that is necessary to support the response. And we had prepositioned in Uganda already what we call Ebola kits that are necessary to support establishment of an isolation and care facility in the early stages of an outbreak. And already one of these kits have been deployed to Mubende, and they are supporting in the repurposing of the treatment center that Dr. Chobe had mentioned about, so that we can be able to have effective management of the cases. Now, in terms of the WHO response from the time that we detected these current cases and up to yesterday, so we've been working together with our colleagues in the Ministry of Health, first of all, to deploy a surge team, a large contingent of, first of all, the Ministry of Health experts, joined by experts from WHO that are supporting in 4 main areas. The first one is in surveillance and case investigation and contact tracing. As Chobe had mentioned, it is very, very important that we quickly identify the chain of transmission, we identify the contacts, we list them and monitor them closely for 21 days. And in addition to that, we are able to identify contacts that develop symptoms and refer them immediately for early initiation of treatment, as Dr. Fisher has ably explained. The second area and then is in terms of the case management, trying to work with colleagues in the Mubende Referral Hospital to ensure that we have capacity to manage the suspected cases and confirmed cases that are in there, ensure that the healthcare workers are protected through provision of PPEs that is very, very essential to ensure that cross or nosocomial transmission within the facilities does not happen. The third one is in terms of risk communication for any Ebola outbreak. The cooperation and participation and ownership at the community level is very, very important. And if the community do not buy into the interventions that we're mentioning, then we cannot be able to control the outbreak. So we've been working with partners across in Uganda and the Ministry of Health on passing the prevention messages to the community, engaging the community structures to ensure that they can be able to cooperate, first of all, in reporting suspected cases, secondly, also in supporting the contact tracing and follow-up, and thirdly, in ensuring that they are taking preventive measures such as avoiding contacts with sick people, washing hands, and ensuring that there is no unsafe burial of any person who dies of suspected Sudan Ebola virus. And then the last one then is in terms of coordination. For any outbreak response, coordination is very, very important to ensure that the responders have all the resources they need at the time that they need, so that they can be able to effectively support the different arms of the response. So we are working on that. And critical then at this point, Dr. Chobe mentioned the route from DRC to Kampala, where Mubende is situated, but also we know Kampala is a hub, and transport between Kampala and Uganda, Kampala and South Sudan, Kampala and Rwanda is very high. So we are working with the neighboring countries now. We have already dispatched our teams to support them to scale up readiness, so that in the event of any cross-border movement of a suspected case or anything, they can be able to detect, investigate, and respond adequately. And those are the main areas that now we are supporting, both this response in Uganda, but also the neighboring countries. Thank you.
Thank you very much, Dr. Patrick, and thank you to all our panelists for this overview. Now that we've heard from all our speakers, we will open the floor to the present journalists to ask questions. So we would like to recall that this is a media briefing, so we ask all people in attendance to note that only journalist questions will be answered. And dear colleagues of the press, remember, you will need to provide a name and the news organization you represent in the Q&A function in the Zoom to have your question taken into account, even if you want to ask a question live by raising your hand. So please, let's stick to it. And so we got first, we have Paul hand raised. I don't know if he wants to go live. And while Paul is preparing, we have a first question from Tony, working with the Daily Monitor, who asked to Dr. Henry, can you explain what the strategies the country has employed to combat the past outbreaks of Ebola? And is there anything unique about this outbreak? And then we'll move over to Paul. Dr. Kyobe, if you can answer quickly, and next in line we'll have Paul.
Oh, thank you so much, Tony. This current outbreak happens just at the end of we think of the COVID pandemic, which we think we successfully managed. And much of the infrastructure that we used, both for COVID, we are quickly repurposing it to Ebola. But also of note, just as Patrick was speaking, we have significant capacity built across within the country for detection and also to be able to galvanize community support and response. So we think that using what we've done before, we should be able to appropriately respond to this current outbreak.
Thank you very much. Paul, over to you. If you can open your mic and ask your question.
Yes, thank you very much. So my name is Paul Adepoju from The Lancet. So my first question goes to Dr. Patrick. Realizing the fact that probably the current vaccine may not help much in this present outbreak response, what is the level of awareness among the general public regarding the non-availability of vaccine, and is this having any impact on their response? And for Dr. William, I would like to know what the potential case fatality ratio could be, and whether the level of awareness regarding COVID-19's public health response could actually make the public to still be able to be calm and do necessary precautions that could be important in spite of the non-existence of a potent vaccine. Thank you very much.
So, Doctor, over to you for the answer.
Thank you. So in terms of the first question, this is not the first Ebola outbreak that Uganda is experiencing. And in the past outbreaks, we have seen very high levels of community awareness and cooperation in the response. So one of the things that we are relying on then in this particular response is that the communities will continue to cooperate and work with the responders. We have not had any challenges up to now. So the teams that are on the field, we're talking to them this morning, they are receiving cooperation from the community in terms of investigation, listing of contacts, and referral of suspected cases. So that is something that we encourage the communities to be able to sustain for this particular response. The second one then, in terms of the non-availability of a vaccine, and also the previous responses that has been done, it's only the one, the last outbreak that was the case imported from DRC, where we were able to deploy the vaccine in Kasese when we had the Ervibo vaccine available for the Ebola Zaire strain. But the response to the prior outbreaks have been effectively done with the principles that have been used before in terms of early identification of cases, early isolation of cases, and management of cases in treatment centers, and engaging with the community so that they can be able to take preventive measures. And communities have always complied with the public health interventions that have been put in place. So we believe that implementing these same measures this time, we will be able to contain the outbreak without having much further transmission. And the authorities, both at the national, the district and sub-county levels in Uganda, are fully engaged in this. And we believe that the cooperation across the whole of society is necessary and will be relied upon to contain the outbreak. Thank you.
Thank you very much, Patrick. I see that Dr. Ana Maria has raised her hand, so please, Dr. Ana Maria, chime in. And also Cesar, also I think you want to say something more. So Dr. Ana Maria and then Cesar.
Yes, I just want to add to what my colleague Dr. Otim just said is 3 points. The first one is that since the Ebola outbreak in West Africa, WHO and partners have worked to integrate research as part of the response. And we have successfully done that for vaccines, for treatments, and for other critical elements of research, because as Professor Muñoz Fontela said, this is our opportunity, outbreaks, unfortunately, our opportunity to learn more about these viruses and how to contain them. So integration of research during the response is now bread and butter of our lives. Number two, even when we have vaccines, vaccines are just one of the elements of containing an outbreak. The other critical elements like contact tracing, containment, isolation, the laboratory, infection prevention control, just to name a few, are equally important. So from the WHO perspective, vaccines are not the silver bullet to resolve the issues related to outbreaks. And number three, we are confident that in collaboration with the Ugandan government and the highly qualified Ugandan researchers, we will be able to evaluate candidate vaccines in this outbreak if the number of cases continue to increase. Thank you.
Thank you very much. Over to you, Cesar.
Thank you. No, I don't have anything else to add. Just to reinforce the idea that at the R&D blueprint we are having all developers discussing in the same table, and I think this is going to be really important for the implementation of the vaccines. So basically, just reinforce what Ana Maria said already. Thank you.
So another vaccine question. So I'm staying with you, Cesar and Ana Maria. From Will with the Telegraph, how quickly can trials of the candidate vaccines be launched, and what sort of time frame are we talking about?
Yeah, that's the question. So as I say, and with the modesty, thanks to the work of our member states and this preparatory work, we have been able to initiate research and studies very quickly in Uganda, in Sierra Leone, in Guinea, in Liberia, in Sudan, in other countries, in response to outbreaks as part of the response. What we are doing now is, as Cesar says, we have all the developers around the table. They are sharing their information on their candidate vaccines very quickly. We will have a follow-up call tomorrow. We will identify which of the candidates have first the data that is sufficient to move into a phase 2/3 study. Second, we will see if they have the doses of the clinical grade material available for the study to start. That's the first part. The second part is the preparatory phase in the country, the approval of the protocol. We already have what we call a core protocol, that is a design that includes all the critical elements to conduct a robust evaluation of the candidate vaccines based on our experience on Ebola virus, but also Marburg vaccines. So we have that ready. It has to be adjusted to the Ugandan situation with the Ugandan researchers' inputs and with the approval of the National Regulatory Authority in Uganda. And then we have to move into deployment. But as my colleague Dr. Otim mentioned, we have already the supplies ready to be deployed for trials and to not delay through procurement issues, etc. So we have three critical elements ready, moving fast. If everything goes without anticipation, and if we unfortunately have additional cases, which we hope not, but if we do have more cases, we could trigger a trial within a few weeks. And that's the experience from DRC, from Guinea, from Sierra Leone, and from Liberia and other countries. But as I said, in doing this fast, we are ensuring that we comply with the international standards, the Ugandan regulatory standards, and the researchers' capabilities and qualities. We are not cutting corners, we are moving forward. And the candidate vaccine that will be tested will go through this independent, really peer review process that we are engaging with the researchers. And I must say, I want to thank on behalf of WHO all the developers and the partners working on these vaccines, because as Cesar says, they came promptly to the table and they are sharing in an open and transparent way the evidence, and they are ready to collaborate. So we have all the elements to move forward as fast as possible.
Thank you, Dr. Ana Maria. Over to Billy, maybe to answer to just add a quick compliment on the treatment part of the question that was asked by our colleague. Billy, if you can go on, and please, our next. So we have then Patience Etouer next, and then Walter Meswege for the questions. Dr. Billy, if you can open your mic and bring that compliment, and then okay, then we have Patience and Walter.
Great. Okay. Thanks so much, Rosemary. And I'll just answer Paul's second question about the case fatality rate, which has previously been mentioned is anywhere between 25 to 90% is being reported. But I would argue that we have the potential to decrease this with all of the complement of interventions that Dr. Hane Restrepo, Dr. Fontella, Dr. Babasa and a team have mentioned it with a full complement of response and with good partnerships with the community. If we can quickly identify individuals who are sick, provide really good supportive care, as we can improve the outcomes and we can drive down that case fatality ratio. So I don't want to use a specific number, but what I want to say is that we're working really hard to decrease that every single day. Over.
Thank you very much, Willie. So over to you, Patience. Can you please open your mic and ask your question?
Hi, my name is Patience Atwere and I work for the BBC. I would just like a little bit more clarification from Dr. Chobe on the numbers, because there is information going around about a couple more probable deaths. But in his introduction, he talked about 7 new cases confirmed and 1 death. Could you kindly just clarify for us where do we stand in terms of the numbers?
Dr. Chobe, over to you. And please, Walter, be ready next.
No, thank you so much, Patience. Of course, the confusion with the numbers comes from the sources that are not coming from the Ministry of Health or WHO. But as far as we know, as I've explained, that the deaths, both the confirmed and then the probable cases, as we classify them, stand at 1 confirmed case death and 7 probable cases deaths. And that makes 8 deaths attributable to this virus, to this outbreak now. Now, the cases that you're talking about are, which have been reported through the alert system, are being verified. And some of those that you're talking about, we have not come to our attention. Thank you.
Thank you, Dr. Chobe. Please, Walter Meswege, can you open your mic and ask your question?
Thank you very much. My name is Walter Mwesige from NTV Uganda. And I would like to know what the implication will be for the non-response of the existing vaccine to the Sudan strain. Does that mean that people who are already vaccinated with the Zaire vaccine are endangered, or they can fall sick from the Sudan strain? But also, what are the long-term effects if one heals or recovers from Ebola? And lastly, to Dr. Chobe, did Uganda find the index case for the Ebola? Thank you.
Thank you. So over to Ana Maria or Cesar on vaccines, and then we'll go back to Dr. Chobe to talk about the index.
I can, yeah, sorry.
You want to start, and I'll follow if you want.
Yeah, I mean, I can answer the first part of the question. So even though these 2 viruses, Sudan virus and Ebola virus, belong to the same genus and the same family, they are quite different viruses. So that means that it would be the same to have a flu vaccine against H5N1 and a flu vaccine against, if you're immunized against swine flu, it's not going to affect whether you're immunized to avian flu. So it would be a situation similar to this. So when you are immunized, you're going to produce a library of antibodies. It's possible that in some people, by chance, they have antibodies that recognize very conserved areas into viruses, and there may be some cross-reactivity, but in the general population, it's not going to be the case probably. That is why it's important, as we mentioned before, to foster the development of Sudan-specific vaccines. The people that have been immunized with Ebola Zaire vaccines are not going to be our more or less risk, because it's simply a different virus.
Yes, and I just want to say that in the case of the RBSV-CoV vaccine produced by Merck, that is called commercially Ervebo, that has been used twice in Uganda, first as part of the Ebola response to the DRC outbreak in 2018 to 2020 in the border areas, and the more recent outbreak. The information available to us suggests that it does not induce what we call cross-protection, so protection across the species of viruses. For the other vaccine that has been discussed in the media, that is called the adenovirus 26 modified vaccine Ankara, there is phase 1 data and animal data that suggests that they may also protect against Sudan. But as for any other candidate vaccine, we need to have sufficient data on the immune response, immunogenicity data, and sufficient data on the clinical response, clinical efficacy data, to conclude that it also protects against Sudan virus. This is what I mentioned. There are three candidate vaccines that we are considering. One of them is the adeno 26 MVA vaccine, but there are other two that have a similar level of evidence. And it's very important when we communicate this that we do not confuse via the media the population. It is very important that people understand that the control measures applies to all of them, including those who may have received other vaccines, and that the efforts to develop vaccines specific to this virus are ongoing. Thank you.
Thank you, Dr. Ana Maria. Maybe we can go over to Dr. Billy to discuss complications of survivors, and we'll keep the discussion rolling. Dr. Billy, please.
Thanks, Rosemary. And thanks, Walter, for that question. I think that's a really important issue, or what are the long-term complications of patients who survive Sudan virus disease and Ebola virus disease? And again, I think we've learned a lot from our experience in the large epidemic of 2014, and more recently in the outbreaks in 2018, that we do see lingering effects of surviving this infection: joint pain, muscle aches, fatigues, much like some of the things that we see with people surviving COVID. And WHO has really led the way in galvanizing a global effort to better understand these long-term complications, as well as to think and design interventions to try to improve those complications. I will say that we do start to see them get better over time. And so I think that's an important question, and it's part of the comprehensive response. It's not just taking care of the patient when they're sick, but it's also making sure that they have the support, including both physical support and psychological support after their release from the treatment unit. So thanks, Walter, for that question.
Thank you very much, Billy. So we received in the chat a question from Sarah Jerving, working with DEVEX, that will go to that I will ask to Dr. Patrick. Is this response more risky for health workers, as there is no approved vaccines so far?
Thank you, Rosemary, and thanks for that question. So, like Ana Maria has explained, the previous vaccines that we had administered to a number of frontline health workers in Uganda and other countries neighboring DRC does not offer cross protection against the Sudan Ebola virus species. So when you compare a healthcare worker and somebody at the community, definitely the healthcare worker has a slightly elevated risk because they are working in very close proximity to confirmed cases in treatment centers. However, a lot of efforts have gone in to ensure that healthcare workers are able to protect themselves, and we have gained significant experience over the last few outbreaks in terms of infection prevention and control measures. So the healthcare workers currently in the facilities are all people who have been trained, and they are able then to adhere to the infection prevention SOPs that are in place so that they minimize the risk of transmission within the treatment centers. It's also important always that we work to protect these healthcare workers by ensuring that we provide for them adequate PPE that they can be able to use during the care for the patients, and also secondly that we do not overwork the healthcare workers, because we know from previous research that fatigue, for instance, can be one factor that can cause somebody to make an accident when they are providing care for a patient. So all these measures are being put in place to make sure that the healthcare workers in this current response are able to provide safe care for the people that need the care, but they are also protected in terms of the public health measures that have been put in place to prevent cross transmission from the patients to the healthcare workers.
Thank you very much, Dr. Patrick. So let's go back to Dr. Kyobe. I have several questions for you. One question will be, did we find the index case? That was the question from our colleague Walter. And also another question from Will Brown from the Telegraph. Could we get some clarification on the geographic distribution of suspected cases? Is there a wide distribution? What is the further distance between two cases? So if you can please answer to those questions, Dr. Kyobe, and then please, our colleague Byamukama, get ready to come on live for your question.
Thank you so much for the question. I'm actually in Mubende, where the epicenter is. It's too early on in the day, just 72 hours since when we had the confirmation of the pandemic, and where we have the investigations have not yet been able to see who the index case was, but our major concentration largely now is on tracing contacts, care for the patients, and protection of the health workers, and spreading the information to the people around to make sure that we spread it there to stop the control, spread the transmission. But also we know certainly that usually the transmission begins from the wild into the human population. We'll get to that. And of course, there's some hypotheses that have been put across before relating to the mango seasons and the end of the mango seasons. Of course, we shall be looking into this, where at the end of the mango seasons, and again, people start, most like children starting to eat whatever they find. But so all these are still hypotheses that we'll try to follow through and understand what the origin and certainly find the index case. The question on the geographical location or the geographical distribution, very, very important. As I said in my opening remark, were that mainly the epicenter is in one district, Mubende district, which sits nearly in the center of Uganda. But within that, we have up 5 sub-counties, both cases, and of course, one case from a neighboring district. We're looking at a span of something like 70 kilometers from one end to the other. But the clusters within the sub-counties, we are looking at the distance of up to 20 to 30 kilometers. But as we know, our breadth of response is the whole country. As again, our team showed that we are on a major road highway from DRC, connecting through the same area here to South Sudan. And of course, being able to extend a response across 11 districts that are surrounding the district where the epicenter is. Thank you.
Thank you very much, Dr. Kyobe. So I think our colleague lost his signal, so we'll go over to Sola Godimpe for the next question. Can you open your mic? Sola? Can you open your mic, please, and ask your question? Okay, so we'll wait for Sola to get ready. So in the meantime, I have a question for you, Dr. Patrick. What are specific regional concerns that make this outbreak distinctive, and how close are the numbers reported? Are they close or accurate? This is a question from our colleague Fred Ojambo from Bloomberg News. Over to you, Dr. Patrick.
Thank you, Rosemary, and thanks to Odiambo for this question. From a regional perspective, I think I had mentioned earlier, one fact that Dr. Chobe has mentioned is the location within the country. But secondly, also mentioned is that Uganda, particularly Kampala and the surrounding area, is a hub. There's a lot of movement in between Uganda and DRC and South Sudan and Rwanda and the whole of the East African community per se. So what we have done as WHO, we did some risk assessment, and we have prioritized these countries in terms of enhancing readiness. I would also like to state that in the context of East African community, we have been working at cross-border collaboration between the countries in East Africa for preparedness and response to public health measures. And there are already established frameworks within which the countries are able to rapidly share information, investigate and follow up contacts across the border, and be able to coordinate in terms of the implementation of public health measures. So the concerns the main one would be in terms of cross-border transmission, or maybe we miss one contact moving from one country to the other. But there are already sufficient mechanisms under international health regulations that the countries are able to collaborate and share information and contain this immediately. The second part of the question probably Chobe would be able to answer, but I would like to state that, like Chobe had mentioned, we are within the first 72 hours of this outbreak, and usually it takes some time to be able to investigate and get all the information. Also, the numbers will keep changing because as we are speaking here, there are teams in the field conducting investigation in real time. So we will be able to get the accurate numbers as the investigations are done, and as additional data is brought in, and we are able to interrogate this. So whatever number we have now is as at the information we had probably before we came on air, but as investigations are conducted, this information will keep coming up. Now, let me emphasize this, that the Ugandan authorities have been very, very transparent in terms of sharing of information on any public health event. And we appreciate the transparency and the timely nature in which the Ugandan government shares information with WHO, but also with the global community, so that collectively we can be able to prepare and respond to this. So as COVID has shown to us, any public health event in one country is a threat to all the other countries. So we cannot fold our hands. We always have to be prepared to be able to respond. And so I'm quite confident that in terms of the measures being put at the regional level and within the country, we are able to work and contain this disease as is required under the public health considerations of international health concern. Thank you.
Thank you very much, Dr. Patrick. So we have one question from our colleague Chipo with BTM TV. What has taken scientists so long to discover an Ebola vaccine compared to the COVID-19 vaccine? That question will maybe ask to Cesar if he wants to chime in first, or Dr. Anna Maria. And then please, our colleague Ronald Musoke, if you can get ready to go live for your question.
So should I go first? I think there's a little bit of misunderstanding. There's been a number of years where people have worked on the development of filovirus vaccines, and I have to say that in the last 30 years, there's been a lot of progress. Different platforms, different types of vaccines, and a lot of preclinical studies. The problem is, of course, that as we mentioned before, the number of outbreaks and the number of infected individuals for Sudan virus has been relatively low or much lower compared with Zaire Ebola virus. And that complicates research, and that complicates the development of vaccines and even the development of clinical trials. But I think there's a very strong foundation, and in particular, of course, since everything that we've learned from the West African epidemic, that I think is also going to help to foster the development of Sudan vaccines.
Thank you very much.
Can I add? Just to be clear, since 2016, when we first published our prioritization list for the research and development blueprint, Sudan Ebola viruses were mentioned as a top priority, number one. Number two, we have a roadmap with lots of researchers collaborating. This has to be also to do with science. There has been scientific development in the last few years that have allowed and led to the rapid development and evaluation of the coronavirus 19 vaccines. But these are different viruses. They pose different challenges and different understanding of the immune system in order for us to protect people. First, and second, it's very important to document the clinical efficacy. And unfortunately, for that, you have to have cases because these occur in sporadic, rare outbreaks. This is why we are working with the international community so fast to use this opportunity to accumulate more data and reduce the number of research gaps.
Thank you, Dr. Ana Maria. Ronald, can you go with your question?
Yes, thank you so much, Rosemary. My name is Ronald Musoke from the Independent magazine here in Kampala. My question goes to Dr. Bosa. I was just wondering whether he could offer me an explanation of why there seems to be a time lag between the first suspected case, which he said could have happened at around at the beginning of this month, and the real response from the health system, which started happening around mid this month, around 15th, 16th. What explains the difference between the first incident, rather suspected case, and the real response we are seeing now? Or what took you so long to act?
Thank you, Ronald. So over to you, Dr. Kyobe.
Thank you so much, Ronald, for the question. It's true there is a little bit of a time lag from what we think is the probable cases or the earlier cases. We can't say the index case till when we confirmed. This, as you know, Ebola is much like most of the other tropical diseases like malaria, typhoid. So initially the presentation in the local setting appears to have been seen and looking like other illnesses. And that confounded the fact that there was a little bit of a delay. But as soon as the individual, the 25-year-old male, came to a major facility, were able to diagnose Ebola. So this is in a way expected, but largely because the individuals were actually moving from one private facility to the other where they were seeking care. It's only when they got into the public health facilities that were able to get to make a diagnosis. Thank you.
Thank you very much, Dr. Kyobe. So we received this question in the chat from Lisa Song with ProPublica. So this question will go to over again to you, Dr. Kyobe. So do healthcare workers in the medical facilities named in the recent report have access to the appropriate PPE? And is there any indication of whether this confirmed Ebola case came from a survivor or if it appears to come from a new case of spillover?
two questions. The PPE, of course, we have graduated use of PPE. Those that are working in highly infectious settings, they have different set of PPE. And those that are working in the different areas of the hospital facilities are having different sets of PPE. Yes, the answer is that we have a sufficient amount of PPE. You heard at the beginning when Patrick was saying that WHO deployed an Ebola kit, which are now using in the management of the Ebola patients. But in addition to that, we still had leftover kits, PPE, in COVID that we are still using. So on whether this was, it's certainly, as I said earlier, that this is usually a spillover from the wild. We have no evidence of saturation of Ebola Sudan in the recent past to suspect that it was a spillover from a different outbreak. The last Ebola Sudan that happened in Uganda happened exactly 10 years ago. And we think it's much less unlikely to have been a spillover from that. So we think this is a fresh spillover from the wild into the human population that is currently saturating. Thank you.
So thank you very much. Donc nous avons reçu une question de nos collègues de RFI qui va aller au docteur Patrick, au team. Donc Christina Okello demande, est-ce que les pays voisins devraient s'inquiéter?
Okay.
Okay. Should neighboring countries be
Yeah, should the neighboring countries be concerned? The short answer is yes, because we have seen from previous experiences that it is possible for an outbreak to start in one place and quickly spill to the others. So in the early phases like this, we are encouraging all the neighboring countries to be able to check on their status of readiness and prepare themselves. The good thing is then the authorities in Uganda have already started implementing what we call exit screening in terms of looking at travelers who are exiting the country as required under international health regulation. But also then the short of the answer is that the countries in the region need to, particularly the 6 countries, that is the South Sudan, Rwanda, Burundi, DRC, Kenya, and Tanzania, they need to scale up their readiness and enhance mechanisms to be able to detect any cases and be able to respond effectively. Thank you.
Thank you very much, Dr. Patrick. So this is a question from Paul that I would like to ask to Dr. Anna Maria or Dr. Cesar to answer. So our colleague from the Lancet, Paul Adepoju, asked quick follow-up to avoid ambiguities. What are the frontline vaccine candidates?
Yes. I don't want to be cryptic, but as I told you in a very transparent way, yesterday we have a call because in research, every day new data emerges. So we wanted yesterday to know exactly what information there was on candidate vaccines that could be used for a phase 2/3 trial to obtain more data on immunogenicity and on clinical efficacy. In order for us to choose this vaccine collectively, not WHO, but with the expert groups, we need 3 things. First, to look at the data on clinical, non-clinical data, the data in animal studies and on the laboratory. We need to look at the safety data and immunogenicity data from phase 1, and we need to have the documentation on whether or not the doses of vaccine that are research doses that exist comply with international standards. The researchers promise us, the developers, to look into that, all the documentation, and we have a follow-up call tomorrow. But there are 3 candidate vaccines that I could mention quickly. One is the CHAD3 vaccine that is being advanced by Sabin Vaccine Institute with support from the Department of Health and Human Services of the United States. The second one is a vaccine called CHAD Oxford 1. That is a vaccine that is being developed with support of the University of Oxford. And the third one is a vaccine that is a combination of 2 vaccines, Adeno26 and MVA, modified vaccine and Cara vector vaccine. But again, we are not saying which one of the three or whether or not the three are ready. We are working in a transparent way with all the developers to see that. But there are other vaccines that are moving from evaluation in animals and the lab into evaluation in humans that may have equal chance. When you do research, you don't know which one of the vaccines is the leading vaccine until you have the data on their clinical efficacy. Thank you.
Thank you, Dr. Ana Maria. So we're coming to the end of this virtual press conference. I would like to turn one last time to all of our panelists to hear any final message. You get 1 minute each, so let's be very brief. We will start with Dr. Billy, if you have a final word.
Thank you, Rosemary. I want to echo the words of Dr. Oteem. And when he said that an outbreak anywhere is a threat to lives everywhere. And so when these events happen, we really need to come together as a global community to respond. And I think that's essential. That includes increasing preparedness around the region, but also supporting healthcare workers within the treatment units as Uganda Ministry of Health is doing. But I will leave you with one comment. I think we have tools in our toolbox right now that can help people survive this infection, but it requires presenting early to the treatment unit and providing good supportive care to those individuals. Thanks, Rosemary. Over.
Thank you very much, Dr. Billy. So over to you, Dr. Cesar. Same rule, 1 minute, short conclusion.
Yes, thank you. I mean, I would like to finish again with a message of hope. I think we are much better prepared than before to face a filovirus outbreak. And I would like to encourage everyone to understand and to think about the importance of science. So at the R&D Blueprint, we have developed a new filovirus roadmap. It's a public document. It's open for everyone to provide input. So we have identified research gaps on how we can prevent, how we can treat filovirus diseases in the future, and again to strengthen our capacity to respond to future outbreaks. We really need to fill those gaps, and for that, international collaboration is key, and we're having everyone in the table to move this as fast as possible. Thank you very much.
Thank you. So over to you, Dr. Ana Maria. Short conclusion.
I want to emphasize the importance of research as part of the outbreak, because it's an opportunity to learn more and to understand better how to combat this virus. I also want to emphasize collaboration. And finally, I would like to ask the colleagues from the media to ensure that when you communicate, do not make over necessary emphasis on vaccines as the only way to control outbreaks. I work on vaccines, I am passionate about them, but I think sometimes when we just focus on the vaccines, we mislead the public on the importance of the other control measures. And in this case, we are open to evaluate all the candidate vaccines, and this is how science will progress. If we ensure that we communicate, that we are using the scientific process to evaluate all the different candidate vaccines, and that if we have a candidate vaccine that is successful and has clinical efficacy, it will not remove the need to implement the other control measures.
Thank you very much. Over to you, Dr. Kyobe, for a quick final word.
Yeah, thank you so much, colleagues, journalists. The 72 hours, the past 7 has shown us that this is a rapidly evolving picture, very complex, and the full extent and the scope of which we don't know. We think cases may rise in a few days, and without full extent of all the contacts, the extent may not be known, but you're working so much with the collaboration of other local and international partners to make sure that we care for our people. We ensure safety of our health workers, and of course, making sure that we bring this to the rapid end as soon as expected, and to ensure that we protect our neighbors and they don't have to have cross-border transmission. Thank you so much.
Thank you, Dr. Kobe. And last but not least, Dr. Patrick, or Tim, over to you for your final word.
Thank you very much, Rosemary, and thanks to colleague panelists. I have 3 last messages. The first message is really to emphasize on global solidarity, and it's very, very important when a country openly comes out and declares an outbreak and responds in a transparent manner, that we should continue to work together and enhance our capacities to respond as one single global community. I would like to emphasize that an outbreak anywhere is a threat to health and security everywhere. The second one then is that we have gained significant experience over the last few years, and we are able to use this to respond effectively to contain the outbreak. We need to bring this to bear in Uganda to respond fast to contain this, to protect the communities through all the known measures that we have been using before, and to protect the healthcare workers. The last one then to the media is that we should spread the messages of prevention and not misinformation, and really contribute to stopping the spread of the disease and not contributing to the spread of the disease. Thank you.
Thank you very much to all our panelists. Thank you for our colleagues journalists for their very interesting questions. And so we're wrapping it up now. Thank you, everyone, and goodbye.
Okay.